from there, from the RCC, which is actually where my journey with palliative care really began. So thank you all. And I know that session 1 was supposed to be taken by Dr. Raj. He's one of the major reasons why most of us were inspired to be in palliative care. It's unfortunate that Dr. Raj has been nursing a sore throat, nothing serious, but it would have been too much of a strain on his voice to take this course today. So I'm going to fill in, and I know that I'm not going to come anywhere close to what his session would have been, but I'm going to do my best. And he will be joining us in the course of this program to take other sessions. So fret not, you'll get your fair share of him as well. Also very nice to see some of our friends. I've had the privilege of meeting a lot of people in this group in person, and I'm so thrilled to see all of you here. I'm going to start with sharing the screen, Raju, if I could please.
Yes, you can share.
Yeah. So I know that several of you are already familiar with palliative care, but I'm also mindful of the fact that for a lot of people, this is the first encounter with palliative care. So while it's a vast topic, we're just going to very quickly touch upon some of the salient aspects, if you will, of this discipline. So the picture that you're seeing here, it's a little bit pixelated, but this is a picture that appeared in The Hindu, the newspaper, The Hindu, on the 14th of August in 2016. And there might be some of you who remember the story. This gentleman filed he submitted a petition in the local courthouse asking for permission to euthanize his son. That's his little son over there, who was 4 at the time. This little boy had a very rare kind of cancer, a very painful kind of cancer, and had been knocked about several hospitals and had absolutely no pain relief. And it was so hard on the parents to watch this child go through what he went through that he finally moved court to ask for permission to have his son euthanized. The petition was declined, obviously. And we saw this article in the paper, and we tried to track this family down. And eventually, when we found him, we found that he was admitted to a hospital in Bangalore, and he was in an ICU. Now, we had some very good friends and colleagues in Hyderabad who were good enough to put one of their social workers on a bus, get this person across to Bangalore with morphine, with painkillers, but that person was not allowed entry into the hospital, and finally, into the ICU. And finally, this child died, we were told, bleeding from several places, in a lot of pain, and with absolutely no relief. The social worker who went across also told us that it was the most difficult situation that she had ever encountered in her life, and was very disturbed by it for a very, very long time after that. Now, this is a statistic that came out in 2014 from the National Crime Records Bureau of India. And close to 1 in 5 people in India who commit suicide are people who are suffering from some life-threatening or life-limiting condition. There are several reasons for this. That is not covered in this particular report, but there are many, many reasons for that. One is the distress is uncontrolled, whether it's physical pain or whether it's other refractory symptoms, physical symptoms, etc. But there are also various other reasons why this happens. And as we all know, what a huge financial burden it can feel like when somebody in the family is ill, and what the treatment costs can be. And oftentimes people don't want to be a burden on their families, and they find that the easier way perhaps to spare their family further suffering is to end their own lives. And so this is a staggering statistic. It's a very, very, very big statistic. So one that we as a country need to take cognizance of. Another grim slide, I'm afraid, but our healthcare is ranked amongst the most unsatisfactory in the world. We've come 145th amongst 195 countries. And what is this based on? Based on the quality and accessibility to healthcare. there is a difference between availability and accessibility. Something can be available, but it may not be accessible for several reasons. And we are way behind all our regional neighbors. I know that we have somebody here, Kausalya from Sri Lanka, and well, we rank far, far, far behind all our regional neighbors. So this is also a rather grim statistic. This is a quote by Dr. Sankhamitra, somebody who some of us in the palliative care circles are very familiar with. And he talks about end-of-life care in India, where the poor die in misery and neglect, the middle class die in misery of ignorance, the rich die in misery on ventilators, and no one gets a pain-free and dignified death. For those of you who are encountering palliative care for the first time, I would just like to clarify one very, very prevalent myth. And that is that traditionally, I think palliative care has been associated with end-of-life care, primarily for terminally ill patients with cancer. And while that has been the narrative in most Western countries, that is not really the case. End-of-life care is a part of palliative care. It is only a portion of palliative care. Palliative care can begin at the time of diagnosis. It does come into sharper focus towards the end of a person's life, when comfort care and just alleviation of distress symptoms and management of distress symptoms is required. But it is by no means only confined to end-of-life care. And that is something that we all need to get on board with, because a large part of the time people opt not to go for palliative care because they think that by doing so, they have admitted to the fact that there's nothing more that can be done. And therefore, it is seen as a sign of giving up. And that idea that palliative care means end-of-life care, or it means that we've given up on any other kind of treatment option, very often prevents people from accessing an approach that can actually help alleviate a lot of the suffering that they're going through. So this is something that all of us who are entering palliative care or have been in palliative care, this is a rhetoric that we have to take forward. Now, the Economist Intelligence Unit is a very well-respected group, and in October 2015, they did something called a quality of death index study, which basically ranks end-of-life care across the world. And if you can see where India is, we're right over here. And we came 67th out of 80 countries. And I'm pretty sure that we've slid further down this ranking since 2015. So this is just to give you an overall picture, a snapshot of where we are in this entire equation at the moment. Now, healthcare. There's a report that came out in 2017 that stated that approximately 55 million Indians are pushed below the poverty line because of healthcare expenditure every year, out of which 38 million approximately are pushed below the poverty line because of cost of medication. And so it is pretty telling of a system when something like healthcare causes further poverty, causes stuff like multi-generational debt, and actually inflicts more suffering on the person who's already vulnerable because of his or her illness. And this is something that is a very this is something that is very common. We all have some experience of it, and we all know that when somebody falls sick, exactly what impact it might have financially on the family. But we're going to talk about it a little bit more as we go along. And here's a broad overview. Astana, there was a meeting held in Astana, which is in Kazakhstan, and a declaration was made on the 26th of October 2018. And many of you must be familiar with this idea of universal health coverage. Universal health coverage basically states that healthcare should reach people where they are and when they need it. And it also goes on to say that health for all has to be health with all. And it has to include people in designing and controlling healthcare systems. One other thing that Astana Declaration does talk about is the fact that people should have access to quality healthcare at an affordable price. So if you look at the previous slides that I shared, 55 million people being pushed below the poverty line because of healthcare expenses is absolutely not in line with what universal health coverage prescribes. It certainly isn't in line with the fact that that health for all has to be health with all, and it has to meet people where they are, when they need it. So at the moment, we're not anywhere close to the ideals of universal health coverage. And while many would argue, and I'm one of them, that universal health coverage is a very utopian idea, that it's almost impossible to achieve. Where we are now is not even at a baseline of zero. I think we're far below that. So if we even start making our way towards or aspiring towards universal health coverage, maybe we'll come to a place where we can have a dignified healthcare system, especially for people who cannot afford it. And it's important here, why am I talking about health when this is a palliative care program? Because they are absolutely intimately intertwined. Health is not only the absence of disease or infirmity. It is physical, social, and mental well-being. Now I'm going to ask you this. Is what we are practicing in our country healthcare at the moment? Are we looking at physical, social, and mental well-being? Or are we just looking at the age-old, way of, okay, diagnose the disease, find the cure. If you can't cure somebody, then I'm sorry, that person is expelled from the medical system. Or very often we hear this terrible phrase, I'm sorry, there is nothing more that we can do. So that's where we're at. So what happens to that person's mental, physical, and social well-being at a time like that? So this is something for us to pause and reflect on. And why are we talking about psychosocial care? Because living with a life-limiting or life-threatening illness, or the awareness of approaching death, it causes a unique set of stresses and challenges, right? So just when someone has a physical condition, a life-limiting, life-threatening condition, there is a massive impact on that person's ecosystem. And that ecosystem has various components to it. And we are understanding the factors related to a patient's quality of life is essential in providing appropriate healthcare. So quality of life is determined not just by the absence or presence of pain, of distressing physical symptoms, but also about the overall other aspects of a person's life. So we're going to touch upon all of that in a moment. I'm going to introduce, especially the newcomers to palliative care, to this idea called total pain. And if you'd like to take a second to read what that description of total pain is when a patient reports his or her subjective pain on the pain scale. What is the pain scale? The pain scale is basically something we use to assess someone's pain. 1 to 10, 1 lowest, 10 highest. So where are you on the pain scale? And a person says, I'm at a 4. It is important to remember that the physical pain reported by a patient is compounded or amplified by his or her current life circumstances. Okay. Now, let me take you through a scenario. I'm going to ask you all to just, sit back for a minute and think of a time when, okay, imagine you have a terrible headache. Some of you might be very familiar with migraines. Now, when you have a headache and it is a Sunday afternoon, you're at home, you have somebody who can care for you, a friend or a loved one or a family member, or you might be alone, but in the comfort of your own bed. If I ask you then, where are you on the pain scale? You might tell me you're at a 3 or a 5. But if you had that same headache on a Monday morning, when you're rushing to go to work, you've missed a few deadlines, on your way to work, you have a flat tire, somebody else on the street yells at you, you end up having an argument with somebody you care about very much. And when you get to work, your boss is yelling at you. That same headache, if I ask you then, where are you on the pain scale? Is it going to feel different from the headache you had on that Sunday? So Raju, I can't see the chat box. So Shreya, can you just keep calling out any responses that there might be, please?
So responses as yes and true.
Okay, so that is a very very trivial example of total pain. As we go along, we're going to talk about total pain in a larger context or in a more in-depth, intense context. Sorry. Now, as a clinician, my responsibility is to assess the contributive factors that lead to total pain. So the doctor might come in and check their physical symptoms. They might check their physical parameters. A social worker will go in and check some other parameters. A counselor would have a completely different domain to deal with. So when we assess somebody's pain, we assess all the different dimensions of their pain. Now, how does this happen? Illness-related suffering is much more than just physical distress, as I've already said. There are 4 other components to it. And you can break up these 4 other components into smaller components. So there is the physical component, of course, which is pain, nausea. It could be all manner of things. It could be delirium. It could be anxiety. It could be whatever else. Loss of mobility. Then there are the psychological components. Sorry, I said anxiety. So psychological components like anxiety, like what else? What else do you think could be there? Fear, depression. What else? Shreya, please keep reading the chat box out if there are inputs coming in from the
we have anxiety, stigma of the disease, isolation.
Yeah. Okay, so stigma, isolation, etc., also come under socioeconomic and social. So that is a huge component. And what else would?
Sorry, pre-existing psychological issues.
Yes, they get worse. And even in social components, you see that if a family has dysfunctional coping patterns prior to a crisis hitting, when the crisis of illness or crisis of any other type hits, those dysfunction patterns only get worse. They don't get better. If a family has healthier coping mechanisms before a crisis, it's likely that they will cope better with the crisis when it comes. So yes, pre-existing conditions is a big one. What about financial? What about the economic side of things? What kind of impact does illness have on the financial health of a family? We have enough and more cases where people have taken loans to pay bills, where one of the most common collateral damage, one of the places that collateral damage takes place is a child's education, especially in low middle income families, where a child's education is stopped because the fees for education has to be reallocated towards treatment. So the child's education in future are disrupted. A person who becomes a caregiver loses their job. They're not able to earn. So that's one less person earning for the family. There could be several other components to that. And also the caregiver's health suffers. And I'm sure all of you who've had the experience of caregiving or who have witnessed looking after caregivers have seen this, that the health-seeking behavior of the caregiver changes because the priority is on the patient. There are other aspects like there's cognitive outcomes as well, right? So stress, lack of concentration, inability to pay attention to a task, inability to sleep properly, there's sleep disruptions, there's appetite disruptions, there could be insomnia, or there could be substance abuse. A whole variety of things can be a result of this domino effect of the illness, and that can cause a series of issues in different domains. What about spiritual? What are some of the spiritual components of suffering associated with illness? And when I say spiritual, I would just like to make note that I'm not talking only about religious beliefs. I'm talking about other aspects of spirituality. Spirituality here would be whatever brings you meaning in life, purpose, a sense of direction, a sense of connectedness with the world around you, with people around you. So how does illness-related suffering impact the spiritual domain of a family?
We have some responses like, why me?
Yes.
Is it my karma? Am I suffering? Losing faith, disappointment in spiritual beliefs.
Yes. Absolutely, absolutely. And especially people who have actually lived life by the good book oftentimes can't understand why they've been subjected to this kind of suffering. So yes, there's a huge assault on their sense of faith and stability as well. So like I said, it also goes beyond religious. It goes to the fact that you're no longer connected with the world around you. Now, if I were to ask all of you, who are you? What are some of the responses that come to you? When I say who are you, will you identify by your role as a professional, or will you identify with your role as in your family? What are some of the ways in which you describe yourself?
We have a response from Sriya saying, I'm a human being.
Okay, I'd like that response. But if I were to ask this human being, what makes you you? What makes you unique?
She writes, who's capable of extending myself beyond myself and my family. Avtar Singh has written, being a person belonging to a certain sect.
Okay. Okay, so there are different ways in which we view ourselves. Of their illness, they lose time. They don't have much time left with their families. Their dreams, their aspirations, all of these warrant grief, and all of these losses also warrant any of these 5 stages, so to speak. And another outcome is of illness is, of course, loneliness, guilt, fear, helplessness. These are all very, very common themes running through people experiencing illness-related suffering, whether they are the patient or whether they're caring for somebody they love a lot. And all of these, when they come together in this crazy constellation, can cause immense heartbreak and suffering at a very existential level, along with on a practical level. The social issues that we face when like somebody said, there's isolation, there is stigma, there is all of that. Here's a quote by Jacqueline Johnson, and she said that this disease is isolating, and the isolation can hurt far more than pain. Suddenly you, the person with the disease, is one side of the wall and everyone else is on the other side, the normal side. I'm going to also ask you to take a moment to reflect on how we might be isolating people within our own families. It's not intentioned. But how many times have we seen that when somebody is diagnosed with a particular illness, from the minute that diagnosis comes in, we start treating them differently. Suddenly they're incapable of getting themselves a glass of water. We want to do it for them. We don't want them to make any effort walking, from up the stairs. We'll get the chair for them. We'll open the door for them. We offer to give them a bath. Now, while all of these gestures come from a place of love, what we also do in the bargain is take away that person's sense of autonomy. And suddenly that person goes from being a person to being a patient. So when we talk about isolation, we're not just talking about isolation that we feel with society at large. Isolation can happen even within the family, and it can be very unintentional, but it does happen. So that's something that we need to pay attention to. Shreya, is there anything in the chat box?
No, not yet.
Okay.
Yeah, so one thing we have, we start seeing them as a patient and not a normal person. And also we inhibit them.
Yes, we do that. And like I said, it comes from a place of love, but it does assault their autonomy. And let's remember that one of the medical ethics is autonomy. And it's not autonomy only within a healthcare setting. Autonomy also deserves to be there within the family unit. So let's try and be a little bit mindful about that. And sometimes we see that happening in the families that we care for in our system. And at times like that, it is important to sit down with the family members and point out gently and with compassion that this might actually be alienating the person you love. So those are some of the conversations that we will talk about as we go further along down the series, of course, the next few weeks. There are all kinds of psychosocial interventions that can be done. And this is just listed out here. There's family meetings, there's supportive counseling, there's cognitive behavior therapy based communication, facilitating psychoeducational support groups, bereavement support services, recommendation for government schemes, financial assistance, linking with community resources, vocational training, regular follow-ups. Now, this is just a hodgepodge of all kinds of psychosocial interventions that can be done depending upon your capacity, your training, and resources available to you. So if you see, there are things from a mental health perspective that can be done. There are things that can be done from a social perspective. Facilitation of access to government schemes, for instance, is something that our social workers are extremely good at. And vocational training, I'll talk about that a little bit more in a bit. Regular follow-ups, of course, are important. Now, when did vocational training, for instance, become a part of psychosocial intervention in palliative care? How does that even fit in? So some of you must be wondering, hey, listen, I came into this thinking palliative care is just end of life care. Fine. It's not only that. But now they're talking about vocational training. So where's that coming in from? I'll give you an example. We run an outpatient clinic for children for pediatric palliative care. These are children with non-malignant conditions. So it ranges from autoimmune illnesses to we have a lot of children coming in from the nephrology department with renal failure. We have children with juvenile rheumatoid arthritis, children with congenital anomalies, so on and so forth. And there is a significant, I wouldn't say majority, but a significant number of women who are abandoned by their husbands and families when they give birth to a child with a congenital anomaly for various reasons. Superstition, she's considered damaged, there's whatever. So here is a situation where there is a gender equity issue as well as there's something else at play. Now this woman is left to care for a highly dependent child by herself. Society doesn't allow her to really have too many options. And she probably does not have the education or the wherewithal to get herself a job. So can you imagine what her condition is like? Now, where does palliative care come into this? Psychosocial suffering. We provide vocational training for these women so that they can provide for themselves from the confines of their home. So it could be a small cottage industry type intervention. It could be something that is suited. It's a decision, it's a shared decision that is taken based on her convenience. Now, it's very important to remember that we as healthcare providers don't go and impose in the name of empowerment. Sometimes we go and say, okay, you know what, I'm going to give her a bunch of goats to look after. It'll supplement her income. The lady is already looking after a sick child. She can't be looking after 10 goats. But we feel like we've made a social intervention. So shared decision making comes in not only when determining options for healthcare interventions in a medical setting, but also in social interventions. So that's something that can be done. It goes a long way in alleviating her distress. It brings in a sense of autonomy. It brings in a sense of financial stability, at least to a certain extent. We will also link her to government schemes available for women, or link her to other women's groups that may be able to assist her better. So her overall quality of life becomes marginally and sometimes significantly better. And that also is palliative care, because palliative care looks to treat serious health-related suffering. And this is serious health-related suffering that I just described to you. So we will be going into all of these things in further detail in the weeks to come. So I'm going to skip ahead. The usual model of medical care in India is like this. Thanks to an increase in nuclear families, people migrating to cities, the healthcare system pretty much crumbling in many places or not adequate in their quality. This is what happens. Individuals and healthcare have a bit of a separation. Not all healthcare is accessible to all the people who need it. And what palliative care really aims to do especially what has been demonstrated in the Kerala setup, is to engage the community and bridge that gap. So it's the proper use of social capital. And this is something that is widely talked about on the Kerala model. And while I'm very, very, very proud of the Kerala model, I feel like other states trying to, or other setups trying to replicate the Kerala model is not the answer. It's to take some learnings from it and contextualize it. So not transfer the Kerala model, but translate the Kerala model into whatever works best in your setting by using the social capital in your areas. So there might be certain, there might be certain strengths that you have in your particular community. It could very well come from, a spiritual group. It could come from a very strong individual who is in charge of healthcare. It could come from civil society advocates. It could come from students. We recently completed training of palliative care for students in Kerala. And we know now that when they go out into the world, they are already going to enter it with that lens on. So work on whatever the strengths in your community are, and see how that can help you bridge this gap between the micro and the macro, and bring in a meso concept. Because, like, if you remember what universal health coverage says, is it's health for all, is health with all, and you have to carry the community with you. The ownership has to come to us, and that's when we will make it more sustainable. And palliative care is actually an approach that leans heavily on that idea. This is just a repetition of what the earlier slide was. Services to all people when and where they need them. And this is a picture of Dr. Raj. That's him in the middle with our team and our palliative care assistant, Chandran. And this is them going across to meet our patients in their homes, so that the patient is not dragged through, dragged out, brought into the city, far away from where he lives. And our healthcare, home care delivery system at the moment, Shreya, correct me if I'm wrong, I think we see about 1,350 families in their homes at the moment in and around Trivandrum.
Yes.
Okay. Now, what that allows us to also do is to see their living conditions. What conditions and what resources are available to them. And very often we find that when we go into their homes, there is somebody else in the family who might need a little bit of attention, usually the caregiver. And the caregiver is who we call the invisible patient. And palliative care pays a lot of attention to identifying who the invisible patients in the family are. It could be the children. Because in looking after somebody who's so terribly ill in the family, the children sometimes get a little bit, they're left to their own devices, or people don't talk to them much about the illness. They're left to figure out things on their own. If a child is the one who's sick, and I'm sure our friends from Chennai who work with pediatric palliative care are very well versed with this problem, where if one child is sick in the family, the other child is quite often neglected and may develop behavioral issues. So when we go into people's homes, we see the ecosystem they exist in. And the job of the interdisciplinary team is not just to attend to the patient who is at the center of, who is the registered patient, but also to look around and see who else in the family might need assistance. We aim to do something. We're rolling out a program where we will be doing a comprehensive geriatric assessment of the elderly people in the family, even if they are not our primary contact. So suppose there's a 40-year-old man who has cancer and we're going to see him in his house. We will, and if there are elderly parents looking after him, we need to watch out for those elderly parents. So what we do is a quick comprehensive geriatric assessment where they will be tested along lines of mobility, ability to look after themselves, their vision, their hearing, their blood pressure, so that there's no escalation in their symptoms. Because if something happens, if an elderly parent who's looking after a person who's sick falls down, then you have two patients in that house, and then how are they going to manage? So prevention is also part of our work in palliative care, prevention of suffering. Okay, so I talked about earlier the fact that one of the biggest collateral damages that we see in families is the education of children coming to a grinding halt because the family cannot afford it anymore. So one of the programs that we run in Pallium India is called Kuti Kutam. It's a children's collective where we take over the educational needs of children from disease-ravaged families whose families have been financially destroyed by healthcare costs. This is to ensure that the next generation is not a victim of one person's illness, and that the trauma is stemmed at this generation, because multi-generational trauma is a very, very, very big part of illness-related suffering in our country. So that's something we also look at in our program. And finally, I just want to talk about advocacy. For some, this might be a very, very familiar word. For some, it's a new word. And advocacy is, the definition of advocacy is, it's the act of speaking on behalf of or in support of another person, place, or thing. And because in palliative care, we see the most vulnerable, we see the old, the infirm, the ailing, the elderly, people who don't really have someone to speak for them, it becomes our duty and our privilege to be the people who do that. Now, there's an interesting quote that says there's really no such thing as the voiceless. There are those who are deliberately silenced or preferably unheard. And very often we don't want to hear, all the doom and gloom stories coming out of the people living especially on the fringes of society. But that's a big part of the cohort that we represent. And further down this series, we will be talking about marginalized communities, people who are marginalized to begin with, and then who are further marginalized when they are accessing healthcare. And we will talk about that in more detail. And an interesting thing is the word advocacy, the Latin root word for vox is voice, and the Sanskrit root word is vach, which is truth. So it is speaking the truth on behalf of somebody else. So advocacy, vox, vach, they all have the same root word. And for those of us who have that privilege of being advocates, that is what we do. We represent someone else's truth as well. So what are the different ways in which we do advocacy? Here at Pallium India, we engage different methods. We work with the media, we work with policymakers, we work with legislations. So pretty much anybody who is at some point going to come across illness, we work with them as well. Caregiver advocacy is something that we're very, very, very keen on. Building caregiver advocacy and enabling caregivers to also speak up, because this is it is a very powerful group in my opinion, and there's no one who's quite an expert as much as a caregiver is, because they have a ringside seat to the suffering. And in our healthcare system, we have this really ugly word. It's called bystanders. And if you go into a hospital, the primary caregiver who's there in attendance will often be called a bystander. And bystander, by definition, is somebody who stands by and does nothing. But that's the actual opposite of what a caregiver does. So caregiver advocacy is very important. Patient advocacy is something that we strongly believe in, and shared decision making, so that medicine is not something that is done to a person, but it is done with them, in alignment with their values. So that is a very, very big part of the palliative care approach. And I'm going to ask for questions to be put into the chat box, which I will take in just a few minutes. But before I close, there are two things that I want to share with you. One is the story of a patient who is registered with Pallium India, and she's been with us now since 2019. And she came to us, we found her. She was a blind woman with a diabetic foot who was at risk of losing a limb. And she was a single parent of a 12-year-old boy. This is what their home looked like. She was going blind. He was 12. There was no income. And very often they would be starving. And it was a 12-year-old son who suggested that suicide was the only way out. So I'm going to ask you now that we have gone through the entire process of talking about total pain and serious health-related suffering. What do you think could be done for this lady and her son? Shreya, I'm going to invite you to please, I can't access the chat box, so if there are any responses coming in, please do share them.
Yes, sure.
So just take a minute to think about what could have been done for this lady and her son.
So we've got some responses. Talk to them in depth. Why did they think about suicide? Try to get them a decent home first. Help educate the son. Supply groceries and essentials first, counseling and medical attention. Psychologists to be appointed for both. Maslow's pyramid. She can be provided with vocational support and educate the family. We can give bereavement support.
Okay.
Any other?
So, okay. All right. I'm glad to hear people thinking along some of the lines that have been mentioned. Maslow's hierarchy is actually quite interesting that someone mentioned it. So I'll tell you how the story went. So how did we even come across this lady is because nobody could control her diabetes. It was spiraling out of control. I mean, at least the people that she was going to, and some nurse told her that if she attends the palliative care day celebration, which the government hospital was having, someone there might be able to help. So she pretty much dragged herself to that palliative care celebration, and her son looked around the room, and someone had given Dr. Raj a bouquet of flowers. So that made the son believe that Dr. Raj must be somebody important, and walked up to him and said, "My mother is calling you." And that's how we came across this family. Now, what did we manage to do with this family? Our intervention was largely and firstly social. It was a social intervention before it was anything else. We were able to basically save her limb. So we got her connected to a government hospital. We got her the appointment because neither she nor her son were in any position to go and do it themselves. We found and paid for a caregiver without whom admission to that hospital was not possible for surgery. So typically in a hospital, an attendant is required for, when a particular intervention has to be done, especially a surgery. So in her case, she only had this little boy. So we got her a paid caregiver, and the surgery was done. She was saved from blindness as a result. And she got onto proper medication. Her limb was saved. Our social workers helped her get her ration card back, which reinstated her identity as a human being in our system, and also was able to get her the ration so that she was saved from starvation. And after that, we worked on getting her a better home, a temporary home, and now she's on her way to a permanent one. So that's her story since 15th of January 2019 to now. And I'm very happy to report that this was to me a demonstration of palliative care, and she and her son are actually doing quite well now. So this is what typically a palliative care team looks like. There are volunteers, and volunteers in the community are some of our most important team members because they are our eyes and ears on the field. And we have social workers, we have nurses, doctors, physiotherapists, counselors, and pharmacists also play a very, very vital role. So almost anybody can be part and parcel of the interdisciplinary team. And one thing I want to add here is that because so much emphasis is placed on shared decision making, the patient and the family are also very much a part of the team. So that's something to just put out there. And finally, I'm just going to tell you a little story. I'm going to stop screen sharing now. And so some of you might be familiar with the story, but when I first came across the idea of total pain, it was a very intellectual concept to me. Like how I described, okay, life circumstances impact a person's perception of their pain and so on and so forth. I said, yeah, I got it. I got what that means. And then we went across on a home visit, and I was with Dr. Raj, and we were asked to go and see a man in his house for the first time. And what we heard, so we parked up quite a distance away because a lot of these homes are not accessible by a car. In a lot of our home care visits, we walk the last half a kilometer or sometimes longer distances. And as we started walking towards his house, we knew exactly which house he was in because of the fact that he was screaming so loudly. And finally, when we arrived there, we found him. The house had such a terrible stink to it. It was almost overwhelming. I had a hard time walking into the house. And basically, he was a 40-something-year-old man who was just screaming in agony. And his wife if you've been a caregiver, or if you've been around caregivers who have to deal with that level of pain, you understand how maddening it can be. I mean, you can't function because the pain is just overwhelming, not just for the patient, but you and your sense of helplessness. So she had this really sort of, uh, you know, almost disoriented look on her face. This man had been discharged from the hospital with a feeding tube. And the message the woman got from that is that she has to feed him. No one had explained to her that after a while the body may not be able to cope with food, or that actually it might actually be hurting his system. So she fed him, and the problem we found later was that he had a bowel obstruction. He was not being able to pass his waste, and so not only was he regurgitating, he was also regurgitating waste. And can you imagine the abject humility, the humiliation, and just the loss of dignity in a situation like that. So anyway, the whole team attended to him, but that's when he was asked on the pain scale where he was. So when we first entered his house, he was a 10 on 10. And once the team had attended to him, we saw that pain scale number dropped to 9, 8, 7, 6, but somehow it got stuck at 6. And it just wouldn't move from there. So finally, people were asked to leave the room, and then Dr. Raj, he held this man's hand, and he just asked him, he said, "What's bothering you?" I was quite young in the team at that point, and I said, "What's bothering him?" In my head, I'm thinking it's quite obvious what's bothering him, isn't it? But there was a silence that followed, which I still remember lasted close to 6, 7 minutes. And you become aware of that silence because it starts to feel a little bit awkward, doesn't it? Nobody's saying anything. But this is the beauty of someone who can sit still and hold space, because sometimes people take longer than 30 seconds to respond. 6 minutes later, the fisherman told us that all I wanted was for my children not to be fishermen, but now they're going to be fishermen. Now, so what that told us is that he knew already that he was dying. He knew that his wife couldn't look after them. And he just wanted his kids to go to school, and now they wouldn't be able to do it. So that was his distress. Not any of the other things that was obviously, which was obvious to me. So the Kuti Kutam program that I told you about, it takes about a week normally to get things in place and, fix up, with the school and make sure that the funds are transferred and stuff. But we sped things up in this case. And then within 24 hours, there were 2 people who signed up who pledged to be the children's, benefactors. All kinds of paperwork was done. And so we returned to the fisherman's house the following day. And when we asked him what his pain was, he said 6. And then we showed him the documents, and he said, your children are not going to be fishermen. And he couldn't believe it for a few minutes. We showed him all the documents again. We explained the process. And after some time, we asked him, what's your pain now? And he said 1. So that is total pain. I have to tell you, the man died 3 days later, but he died pain-free. So I hope that with today's discussion, I've been able to paint a picture of palliative care for you. It is a vast canvas, and lots of it still yet to be painted, which I'm going to leave to extremely worthy faculty who will join us in the next few months. And I really hope that you will stay with us over the next 30 weeks or however long this takes, because it is an enriching space. And like so many of you have said, you've been through so many experiences of your own that we would love to hear your stories come out as we do these sessions together. So I'm going to, it's exactly 4:30. So any closing remarks from anybody? I've just seen the chat box, my God. Raju?
Anyone wishes to unmute themselves and speak? We have another 5 minutes before winding.
Very inspiring, ma'am. I think we'll learn a lot from you all. Thank you, Jay.
Thank you. Thank you.
Very inspiring session. Thank you so much, ma'am.
Yeah. Smriti Rana, it's very interesting to hear from you. I've heard you in a couple of online sessions earlier. And currently, post-COVID, I want to learn how you can help me out, or we can help Pallium India as well as a counselor also. Would be very happy to join hands with you and do something.
Thank
Definitely.
you. Thank you, Alpa. I'm so, I can't tell you what joy it gives me to see more counselors and psychologists getting involved in this field. We've always had, I think, a little bit of a gap there. So I'm
Yes,
so
yes.
thrilled. Thank you. Thank you for being here, and absolutely happy to collaborate on any front.
Thank you. Thank you.
It's so relatable what you, the story that you just told us. I've been with Tata and I come across the patient in the final stages, and in addition to the pain, they have the pain, they carry the pain of the children not being settled. So I had a patient who was declared on best supportive care, and his wife came up to me and said, what do we do? So I said, it's time for you to let go. Some things can't change. So the daughter was seeing somebody, and she says, can I get the daughter married so he can see the daughter married? And before he passed away, they got the daughter married. So, he went a happy man. He went, with the knowledge, knowing that one of his duties he was able to do. So yeah, the story that you said is so, so relatable. Thank you so much for a fantastic session. And as Alpa said, I would also love to contribute if I can in any which way.
I'm sure. I mean, and we have a lot to learn from you, Vandana, and for you to go back in there and be of service after all your experiences is just incredible. So thank you so much. Thank you very much. So Raju, I think we're at the end of our session, and we have a session next Friday where, if you want to just tell everybody what that's about.
Yeah, so before that, I have shared a feedback link. So every session will have a feedback in which you can click on the link and then give the feedback of this session. So every session will be having like that. So we can see you next Friday with the topic on interdisciplinary team taken by Binzi. So we will learn more about the team which Smriti ma'am have just mentioned. So thank you all for joining in. In between, you have any questions, queries, anything, please write to us, or you can chat in our WhatsApp group. Thank you, ma'am. Thank you all for joining. Bye.
Thank you, ma'am.
Thank you.
Thank you, everyone. See you next week. We will be sending the PPT and the learning materials to you through email. So you would be getting that. Any queries, anything, just message us on the WhatsApp group and let us know. Thank you for being such great participants today, and looking forward to meeting you next week. Bye.
Thank you so much, ma'am. It was great.
Thank you.
Thank you so much.